Immunotherapy in general is reasonably safe, but there's some certain complications where we need to call on our subspecialist colleagues. So maybe I can ask you, Momen, pneumonitis is just such a feared complication of immunotherapy. What is the role of the pulmonologist to help the team kind of get educated, being able to monitor, intervene, for the right patients?
Yeah, I mean, immunotherapy-related pneumotoxicity has been really hard to predict. So we don't know what patient will get it. We know we have some data that patients who smoke, patients who have COPD, and patients who have pulmonary fibrosis are at higher risk potentially. But it's hard to predict, even with the presence of these diseases, who will get immunotoxicity. So I think, again, education to the patients about symptom development.
Yeah.
If they develop symptoms, respiratory symptoms, and obviously we see changes on the CT, this is where we need to step in and follow an algorithm of how to manage these patients, depending on how the grades. Obviously, pneumonitis has sort of 4 grades or so based on the radiographic involvement, based on the symptoms. And work closely with our oncologists to follow these patients. Some of them we may do a bronchoscopy to try to distinguish between, is this an infection, immunotherapy toxicity, or potentially progression of tumor. And then for the ones that we think it's immunotherapy related pulmonary toxicity, typically we initiate steroid treatment early on. And so I think it's a really collaborative relationship between the oncologist and the pulmonologist. And if you have a high-risk patient that you're going to do immunotherapy on, there might be a role for periodic check of spirometry to try to detect it early. There's some, not so robust data, but some data that in high-risk patients, like pulmonary fibrosis patients. So I would never want to deprive a patient from the benefit of immunotherapy. So for those patients, we work very closely with our oncologists to mitigate that risk.
Great. So coming to you, Jay. So immunotherapy adverse events can develop. They do develop. As a surgeon, when you take the patient to the OR after 9 weeks of immunotherapy, is your heart rate a little higher? Is there going to be some peri-op complication? I have to admit that we had a couple of thyroiditis cases, like right after surgery, adrenal insufficiency. That was difficult to detect post-op because the patient was just hypertensive. Who's not hypertensive a little bit?
Yeah, I mean, I think the adverse event profile for IO is different. And I think one of the, so in the neoadjuvant perioperative trials, we have to be careful that a lot of the data collection is not necessarily long-term, and we don't always pick up on the delayed immune-related adverse events or even the chronic immune-related adverse events. I think that's not captured as well. So it's a new complication profile that surgeons are not necessarily accustomed to. It's not just going into surgery, but even in the immediate postoperative period where surgeons are heavily involved in that first 30 to 90 days, we're seeing some of these adverse events. So it's important to educate the surgical community about that. But I think for the most part, it's a very well-tolerated drug. But I think that when you see that renal insufficiency, when you see that diarrhea and you're thinking colitis, and you got to think about could this be an immune-related colitis? Could this be an immune nephritis, an immune hepatitis? These things that we're not used to thinking about as surgeons particularly, and a pneumonia patient that may actually be having an immune pneumonitis, So I think this is really requires education among surgeons about the adverse event profile.
Absolutely. Again, generally safe, but there's such a spectrum of immune adverse events. It makes us, relearn different chapters of medicine that we thought that we could forget. But now we're challenged to do so. But we're also lucky in academic centers such as ours to have so many great subspecialist colleagues, just like, for example, you, Momen, to be able to call on. What is your practice as to working with the subspecialist teams? pulmonary, endocrine, dermatology.
Yeah.
A bunch of friends we need to kind of keep
It really
close,
is,
right?
and everybody has the numbers and who to contact very quickly. Most of it the medical oncologist can usually handle, but then you have those small subset of patients that no matter what you do need to get endocrinology involved or dermatology, doing a lot of education with the patient. Sometimes you start on a treatment and they're not doing it as well as you expected to, so you need to kind of elevate that with our specialty. Cardiology gets involved too sometimes, so, and of course our pulmonologists. So it's really important to be able to treat what we can treat, but when it goes, we need a specialty, Yep.
Fantastic comments.